Hello, today I have the pleasure of speaking with Dr. Sue Kressly, who is an innovative pediatrician and clinical informaticist with expertise in quality improvement, health IT payment models, and practice transformation. Sue, can you speak a bit on the challenges of attributed panel reconciliation between the payer and the practice, and how the unwinding of the public health emergency and the Medicaid enrollment requirement in each state is going to present significant additional challenges for both practices and payers for the next few years?
Well, I'll be happy to try and tackle that, but that's a lot to unpack. So let's start with why I believe this matters and what keeps me up at night. And first and foremost, it's that I believe that every patient deserves high quality care and access to evidence-based medicine, despite the personal challenges that they might have. And so some of our listeners may not really understand this attributed panel concept. So let's start with kids at a birthday party, and there's a 50 kids invited to a birthday party. And at the end of the night, parents, caregivers, babysitters, come claim their child and say, we're going home now. Well, what happens at the end of the night if there's a group of kids and the adults in the room are saying, yeah, that's not mine. I wasn't supposed to take that kid home. This is not my responsibility. If we do not decide that as a collective group of healthcare providers and payers, that as a community, we are responsible for all the patients together, we're going to have people being left out, and which just causes disparities in care that is actually delivered to patients. And so attributed panels really is who's responsible for making sure that these patients, and in my case as a pediatrician, children, receive appropriate health care. Well, I think it's a joint responsibility from those who pay care, the payer, and the providers and practices who deliver the care. And they must be aligned, because if the payer thinks that I'm responsible as a pediatrician for taking care of a child who moved out of state, I have no way of making sure that that kid gets care, and they are not really my responsibility anymore. And the payer may not know that the child moved out of state, but I do. And so we really need to make sure that we were all on the same page in caring for care. So let's talk about where we are now with the public health emergency and Medicaid. During the public health emergency, the federal government said that no patient should be kicked off Medicaid rolls. We are all trying to do our best to make sure that every patient gets access to good care, and nobody was allowed to be removed from rolls. And all state Medicaids have a fiscal responsibility to make sure that the right people are covered by Medicaid, and there is a validation verification. Do you fit the criteria that you should be covered by Medicaid in your state? During the public health emergency, nobody was removed from the rolls. Once this public health emergency ends, every state is going to have to go back through their entire roll and say, are you still eligible? Do you belong on Medicaid? Should you, are you now covered by an employer-sponsored plan? Do you qualify? How do I connect you to an ACA plan, et cetera? And there is a lot that's going to happen and have to happen in the unwinding of the Medicaid rule in the public health emergency. And I really worry that people, especially kids, who can't say, go apply for insurance themselves, that they're going to get left behind. And I really believe that we got to figure out what this looks like so no patient is left behind. And while I see patients and I may have their contact information, they update their address because they come for care for me. That may not be the address that the Medicaid Managed Care Organization has, and it certainly may not be the same address that the state Medicaid agency has. So now we have a period where we don't even know where the patients may be, and during the public health emergency, especially kids, moved out of state, across state, so that there were aunts and uncles and other caregivers who could help support a collective of everyone working under stress. And I have to say, while I live in healthcare, our patients do not. that is not maybe their first thought. I moved. Ooh, let me call state Medicaid and tell them that I moved, right? They are trying to figure out how to put food on the table, how to pay their rent. There's a lot of unwinding, and I really worry about how we ensure that patients are all covered for some kind of high quality healthcare and have access. And that means that we have to agree. I, as a practice, think these are my patients covered by the Medicaid plan. What does the Medicaid Managed Care Organization think are my patients? And what does the state Medicaid think the Medicaid MCO is covering? And if we don't really get some tools in line to reconcile this and work together collectively, we may not even reach patients in outreach to say, hey, change your address and your contact information. They may be lost and invisible to us, which then can worsen the disparities of care, especially for some of our traditionally and historically marginalized and patients who really have trouble getting equitable care.
So I love the analogy that really hit home, and made us all realize, what this challenge is and how important it is and how everybody really needs to work together because, this has created a tremendous issue and we all need to find out ways to address it.
Yep. Nobody needs to be left standing at the birthday party and every adult leave them standing there without knowing how to get home.
And these are patients that don't have a voice. And, we need to really address that and make sure that, with the unwinding of what this pandemic has caused, that we address this. And I love the analogy. Definitely hit home. So in light of the challenges to practices and with the effort to deliver quality care, additionally to close gaps and be mindful of health equity, what tools do you think can be used by practices to be successful in these areas?
So first of all, let's just remember that we should be on the same team, which is team patient, right? We're all about trying to make sure that the patients get the right care at the right time in the right place. But the payers pay for it, and the providers and the practices are the people who deliver the care. So we have to believe that we are on the same team, and we have separate data silos. So we have to figure out how we work together in partnership with the people who pay for care and the people who deliver care to be able to harmonize and reconcile the data that we have. So I'd first start with some tools that can look at, in my EHR practice management system, which patients do I think are covered by this insurance and are active patients to me, figure out what that looks like to the Medicaid MCO, and ideally, if you had the same roster at the state Medicaid level, we can make sure which match, they don't take much work, which don't, who's got the right information, and how do we reconcile that data in a way that makes sense. So step one is really understanding who your patients are, whether you're the payer or the delivery system, right? And then there needs to be concerted efforts about being proactive, not just reactive. It's easy when a patient walks in front of you and says, I'm here for a sore throat, to react and say, oh, but you're also overdue for your well visit, your vaccinations, some lab work, etc. But that only takes care of those people who present for care and if the already overworked staff happens to notice it. So I think there's two pieces of proactive work that can help. If you have a tool that can identify care gaps for patients coming in for care. My practice, when we did medical home transformation, we initiated a practice huddle twice a day, and a lot of practices are doing this. If you're able to see and you have a tool in front of you and say, here's the kids coming in tomorrow, here's the patients coming in this afternoon, let's look at them, see what care gaps they have, and before that patient gets there, have ready that lab slips. Call them up and say, I understand you have a sick visit, but we're going to turn it into a well and a sick because you're overdue for your preventative services. So be prepared. We're extending the length of time. And if you do that proactively, you can put time in your schedule. And so that the patient, the family, and the provider aren't rushed. So I think tools to be able to identify care gaps for patients coming in for care matter. But then there are the ones who aren't coming in for care, right? You want the ones that are invisible to you. You may have seen the 2-year-old sibling, but the 6-year-old you haven't seen, right? How do you figure out where are the kids or patients who are on your panel and you haven't seen for 3 years? Are they really still in your state? Are they coming to you? Did they pick a different doctor down the road? So you need to have some kind of processes, but it all starts with data. Show me the patients that I think should be mine, and then some processes that are implemented, integrated within your recall workflow, your patient engagement platforms, to be able to identify those patients, get them in, engage them, and help to deliver a care that is patient and family focused. We tend to use tools, and I like to point out there's a difference between equality and equity. Right? If you give everybody the same thing, like a text reminder or an email, that's not what everybody needs. Some people are already engaged and don't need to be reminded they're coming in for a well visit. Some families have struggles, and in order to be able to engage them, they need a personal phone call or a text or a different kind of message. And they may have a barrier to even coming in. If you're having patient hours 8 to 5, and they have a single mom working 2 jobs, she can't get there in that time frame. So remember that equality is not equity. We have to give each sub-patient population what they need and be able to use outreach and engagement. And that all starts with data and understanding first of all, who your patients are, and then having a better understanding of what they need.
Thank you, Sue. I think, seeing all the challenges that providers and payers have, a lot of good information. Obviously, we have to do a better job always to engage patients, especially, certain adolescents are always a big challenge. So to be creative and to have the tools and to have the passion that you certainly have to care for your patients is critical. So thank you again for your time.
Thanks for having me.